Okay, great. So today I've been tasked with discussing briefly management of the undescended testis and hydrocele in kids. And as you all know, I am about 40% out here in Northern Virginia and 60% downtown, having started my practice about 20 years ago in 2002. And being very tightly connected to the Northern Virginia community, given the fact that, well, I just live about 15 minutes away from the PSV. So what we're going to discuss today is what you as non-pediatric urologists should know about the established guidelines for the management of cryptorchidism. And then we'll also review hydroceles after. We'll go through the following definitions. First, most undescended testes are congenital, so it's a defect of development, but there are a few that are acquired over time, either because of somatic growth or sometimes very rarely because of surgery. So in a child who previously had a hernia or previously had an orchidopexy, there is a risk for secondary ascent. We'll talk about the location. There are very few of them that are extremely high and in the abdomen, with the majority of them being distal to the internal ring, so in some inguinal, prescrotal, or ectopic location. And when we discuss undescended testes, we also discuss the vanished testis, because this would be one of the reasons why a testis is not palpable. And retractile testes, of course, always come up, because is retractile testis a normal developmental milestone for kids, or is it pathological? In the vast majority of kids, retractile testes are a normal developmental process, but then a few of them may ascend. And so is it that the retractile testis is at risk for ascent, or is it that you have sort of two things that are both true and really unrelated in the same child? And then lastly, the atrophic testis is a testis that was manipulated and died. So perhaps underwent a pexy and did not survive its trip into the scrotum. Or you could have a testis that unfortunately, because of severe inflammation, perhaps a bad chemical or bacterial orchitis or torsion, did not recover. And as a result, the testis is now smaller than it was before. So those are the definitions that underpin basically what we're talking about. The minority of testes are located in this abdominal location. And when they are abdominal, they are actually, as this little cartoon depicts it, just inside the internal ring. And so when we perform a surgery on these, generally we're basically coming in at this approach, and we find them right here. And then there are some real swirly testes that are what are called peeping. So sometimes they're here, sometimes they're there, sometimes they're here, sometimes they're there. And by and large, I know this to be the case when I feel a testis in the office, and then when I re-examine the child under anesthesia, I can't feel the testis. So I know that the testis is sort of going back and forth. And if you are sometimes sort of the same experience where you're like, gosh, I know that I felt it, I'm not going crazy. I know I felt it in the groin the last time, and now I don't feel it. It's probably because you're dealing with a peeping testis, which is going back and forth. That being said, probably about 80% of undescended testes are going to be located from here and down, or a smattering of them are going to be what's called ectopic, which is not along the true course of the testis. So this is the true course of the testis through the inguinal canal and down into the scrotum. And these are ectopic. So this testis, even though it looks like it's in the inguinal canal, it's not. It actually comes out of the inguinal canal and then slips in front of the inguinal canal. So it's literally sitting on top of the fascia. And then these other ones can be located either in the femoral region or perineal or in a prepubic, prepenile space. And so how does this all happen? Well, believe it or not, it's actually quite complicated, and there's kind of two uh, um, sort of phases of testicular migration. So the first phase is in the first trimester. And what happens is that the testis, which is forming actually very close to the kidney, needs to move down from that retroperitoneal location into sort of a holding pattern right inside the internal ring. And so this is the part that generally goes well in almost all kids. And you can imagine where those kids who suffer from intra-abdominal testes, basically at the first trimester, nothing else happens. So phase 2 did not actually happen. And phase 2 then requires swelling of what's called the gubernaculum. And this is an attachment that precedes the testis. And this swelling actually perforates the abdominal wall and creates a pathway through, and then the testis essentially will follow that pathway as this gubernaculum dissolves. And the pathway that is generated brings along with it peritoneum. And so this is the reason why in the normal child, the testis is actually surrounded by, in effect, an island of peritoneum that is sitting down in the scrotum. And there's a small amount of fluid that exists in all boys. So if you do a scrotal exploration in any boy or any male, you'll find a few droplets of fluid that I describe to parents sort of as oil lubricating your engine. And just like you get oil in the pistons for things to sort of move around, you also kind of want this fluid, excuse me, you want this fluid around the testis to allow it to sort of move freely within the scrotum. And it's this peritoneal tongue that comes down into the scrotum, which then explains why hernias and hydroceles develop. So in a male, in any male, if there is inflammation of this peritoneal covering that exists within the scrotum, then you can have an imbalance between fluid made and fluid absorbed, and then you end up with a hydrocele. And these reactive hydroceles are fairly common when a child will have orchitis or torsion, or sometimes hydroceles will develop in this space even as a result of viral illnesses. And we see these hydroceles sort of come and go associated with a viral prodrome. We know that there is a genetic predisposition for this because we see a higher association in brothers as well as twins. And if a father has had cryptorchidism, then there is an over 3 times higher risk that the son is going to have cryptorchidism as well. We believe that there may actually be a maternal contribution genetically to this. And we know that there are genes that do cause some susceptibility, but ultimately it's felt to be multifactorial. That being said, there are a number of syndromes in which cryptorchidism is a presenting feature. And it's the commonest one that we all know about is Beckwith-Wiedemann syndrome, which as well as prune belly syndrome, where their bellies have no musculature in the middle and lower portion of the abdomen, giving the classical prune appearance because what you're seeing through the skin is the small intestine. Cerebral palsy, although it is not a genetic syndrome, there is a high degree of testicular ascent. So they have acquired undescended testes over time. And it's felt that this may be a result from the spasticity that one sees in patients living with cerebral palsy. And of course, the muscular covering of the testes, which causes the retractile testis, may be influenced by this spasticity. So it's a common problem. On any given day in the clinic, I see a bunch of kids with concerns for undescended testes. And so we typically say that between 1% and 3% of term infants have undescended testis, but the incidence goes up the younger the child is. That's to say, the more premature the child is. And if you recall that the second phase of testicular descent is happening in the last 1 to 2 months of gestation, then it makes perfect sense that a child who may be born not a 40-weeker, but a 36-weeker or even a 32-weeker would have a high likelihood of undescended testis. And even in term infants, though, it may be that the process of this second phase of descent may not be completed. And so even though there may be cryptorchidism diagnosed in the newborn, that is to say that the infant under 1 month, there is up to a 25 to 40% chance that that testis may complete its descent in the first 6 months of life. And so it's an issue of timing, right? It's a lead time bias, if you will. So what we generally would say is that any baby that's born with an undescended testis, even if it's a newborn, a full-term newborn, then what one needs to do is add 3 to 4 months to that sort of 40-week age, and then that should be your expectation, if you will, for when the testis should be in the scrotum. So if it's a 36-weeker, then you add 4 weeks on to the typical 3 to 4 months, and so forth and so forth. So what should we, so what are the guidelines basically say in terms of the evaluation and management of undescended testes? So first, as I alluded to in the previous slide, gestational age is critical because that's going to inform your expectation of timing of descent. Was the baby born with a low birth weight? And are there other maternal risk factors present, such as diabetes, smoking, and hypertension? Second is to palpate the testis for the quality and the position at each of the normal recommended well child visits. So this is a standard, and of course all of you guys perform a normal full physical examination anyways, but what this speaks to is the idea of tracking position over time, because by tracking the position over time, you're going to then be able to understand whether this is a testis which is still within the opportunity of spontaneous descent in the very young, or if it's a testis which was scrotal and appears to be ascending over time in a child who is perhaps elementary school age, which sometimes we see. And then to refer infants with cryptorchidism who do not have spontaneous testicular descent by 6 months of age corrected for gestational age. And I would say that any child who is over 6 months of age who doesn't have testes in the scrotum needs to be referred. Now, that doesn't include children with retractile testes, because as I said, retractile testes are in effect a sort of normal developmental process for kids. And the tough thing is figuring out who has retractile testes and who has testes that are really not in a scrotal position. So the issue of timing then is a critical thing, because over time there is a lesser chance for spontaneous descent, and there's probably an increased risk of damage to the testes. There was a series of really very well done studies out of CHOP in the 80s and 90s that we probably would never be able to do now, where what they did was they biopsied at the time of orchidopexy the testis that they were bringing down, but they also biopsied the normally descended contralateral testis. And what they learned was that the undescended testis begins life with fewer sperm-producing cells. These cells are called adult dark spermatogonia, and they exist even at the time of birth, despite the fact that one does not expect for sperm production to begin for at least 13 years. However, the potential cells that go on to produce sperm are already present and can be measured. And the number of these adult dark spermatogonia are fewer in undescended testes. But then what's interesting is that beginning at about 16 months of age, if the testis is still in a non-scrotal position, the number of adult dark spermatogonia begin to decline. And it's a progressive decline that doesn't occur over months, but over years. But it is a progressive disease state that results in subfertility in testes that remain in a non-scrotal position by the time children arrive to puberty. So while the testis at puberty will produce testosterone, that undescended testis, if it has not been brought down by puberty, likely will not produce much, if any, sperm.
So, Dr. Pohl, just to kind of clarify for myself, so there are a number of kids that I examine that, you know, the testis, I call it high riding, but I can pull it into the scrotum fairly easily. And I always ask the parents to check in the bath if, you know, when they're more relaxed, you know, do you see testes being down? But is that a problem? Like if because that happens all the time. I say, oh, the right testis or the left testis was high riding, but I was able to pull it into the scrotum. Is that going to be a problem for sperm producing cells later in life?
No. So if it's high scrotal and it cannot be pulled down into a more dependent location, then that is potentially an issue. Okay, but if it's high scrotal and it can be pulled down into a lower position, then it is not an issue. And you know, those of us who have examined a lot of these, you get there's a subjective feeling of elasticity on that cord.
Right.
And so there are some kids who, when you examine the one side, it is clear that the cord is elastic and the testis can be pulled all the way down. And then on the other side, when you pull on it and there's this resistance, it just doesn't want to come all the way down. Those cords, those testes probably should be included in the undescended testis category.
Oh.
And so if you track them over time, there's a higher likelihood for those to ascend. So the description, it's not really that the testis is moving up. It's because the cord is of fixed length and not elastic. The boy just gets longer. Okay. And the testis stays in place. Okay.
Okay. So those should be referred.
Yes, those taut cords should be referred.
Okay.
Because there's a higher likelihood that they're going to ascend. Or at least they should be on a very close follow-up protocol with you to make sure that they remain in a scrotal position, you know, every time they come back.
Okay.
And the time to really focus on testis position is the time of highest linear somatic growth. So if you track their growth, you know, on the growth charts, and then all of a sudden, you know, some of these kids will do, they'll sort of like tick up a couple of lines, right? And then so make sure that the testes are still in the same position as they sort of, you know, have their little growth spurts.
Okay. Yeah, because there have been some boys that I've seen that honestly, like their scrotum seems very under developed.
Yes.
And quite frankly, they didn't even really know what I was talking about when I said testes or when I said balls, because I don't think they ever really, this one particular boy didn't ever really see it.
Yes.
Now I did send him, and I thought you guys were gonna do surgery on that. But I think actually I sent it to another place, and they said, oh, I could get it into the scrotum, but I mean it took a lot to get it there. And then
yeah, I worry about those scenarios
I
where
do
there's a
too.
lot, yeah, where there's a lot of work that is required to get them in there.
Okay, I was just making sure I'm not losing my mind on that one. I thought, man, maybe I should take him to the OR and try to bring the testicles down. I wasn't
Yeah,
going to
no,
do that, by the way, but
yeah, no, I figured not, Suzanne.
okay, good.
So, so I think that I did that. Yeah. Okay. So now in terms of the exam, so Suzanne brings up an excellent point, which is that of relaxation. So the pediatric urologist is benefited by the fact that we are more likely to perform a focused exam that begins with the genitals and ends with other things that are of less interest to us, as compared to the pediatrician that performs a classical physical exam that begins at the head and works down to the toes. And so what generally happens, having now taken my son to 9 yearly examinations, you know, the kid is naked or half naked or in underpants or something like that, sitting in, as you know, a 70-degree room waiting. And during this time, the testicles, which are sort of like little squirrels, they kind of go up there and they hide. And so by the time you get to the genital exam, it can be a challenging thing. So this recommendation to have the parents participate in data collecting is very good, because sometimes the parents will come and this is not meant to be disparaging, but they'll say, I don't know what my pediatrician is talking about. Whenever the kid is in the bathtub, I see them there. And it's a no-brainer, because of course the kid is relaxed in warm water and they're sitting. And the sitting position is a key maneuver for kids, especially with highly retractile testes and with small scrotums. Because anyone who has examined many kids knows that you put them in the supine position, and there are many testes that then are inguinal unless you milk them down and tire the cord by holding on to the testis so that the cremaster muscles fatigue. And once the cremaster muscles fatigue and you release, you should see the testis remain in the scrotum for a period of a couple of minutes until the cremaster muscles regain their ability to contract, and then pull the testes up.
How long do you have to take to tire the cremaster?
Yeah, I mean, that's a good, probably sitting there for a minute or so.
Oh.
Yeah, but again, people are increasingly busy, and some kids are not going to allow you to stand there manipulating their testes for a long period of time. And so there are a variety of other maneuvers that can be done. One is what's called the catcher position. So anybody that has watched, softball or baseball knows that the catcher is in this squatting position. So one could certainly take the kid's pants and underwear off and ask them to sort of squat like a sumo wrestler or a catcher. And the fact that the thigh is now flexed, this inhibits the cremaster reflex. And so the testis should be in its normal position. And that's the reason why when the kid is in the bathtub, you see the testes down. It's not so much the warm bath water, it's the fact that they're actually sitting. So when I perform exams in the office, as soon as I can get that kid sitting up, which as you all know is easily at the 6-month-old stage or so, and sometimes they need to be propped up a little bit and held in place. But as soon as I can get the kid to sit up, I actually focus on my physical exam with the child in a seated position. And when the child is in the seated position, then this cremaster reflex goes away. And so very many testes that I see in the office that are being referred to us are actually normally placed testes that are just highly retractile. And in the older child, early elementary school age, you can actually then demonstrate to the mother and father by stroking the inner thigh and using the cremasteric reflex and say, see, this is the muscle that sort of can pull it up and down. And so it becomes, a fairly easy thing to figure out. Now, if the testis is not palpable, then one of the things that you want to do is to look at the normally descended testis and see if that testis seems to be of a normal size to you. Now, this is a subjective thing, and it's a little bit more difficult to sort of figure out. You have to really look at a lot of testes and really assess them for the normal testes in normal boys for size. But in an infant of about a year or so old, if the only testis you feel seems to be a big testis, then the opposite testis probably was lost at birth because of prenatal torsion, and is no longer present. It doesn't mean that it necessarily stops the algorithm from proceeding to surgery, but it basically just gives us additional information. So
would you recommend an orchiometer or no to look at testicular size?
So there have been a lot of studies that have tried to quantify this volumetric assessment, and they're not really good. Measuring by ultrasound and orchidometer, the correlation isn't as high, oddly enough, as just the subjective impression of hypertrophy, and I don't understand why that is. But the subjective impression, whether it's more than 2 cms. So most of these are palpable testes. As I said, they're distal to the internal ring, and of the 30% or so that are not palpable, the majority of those are intra-abdominal, and another 30% of those non-palpable testes are actually very small testes that are hiding in the groin or the scrotum, with 15 to 20% of them as being prenatally torsed testes. Now, if you tell me that it's the left testis that is not palpable and the right normally descended testis is hypertrophied, I have about a 90+% chance of finding a dead testis in the scrotum, because now you're starting to sort of add all of these sort of covariables up, and the left testis we know is at a higher likelihood of torsion than the right testis, and for reasons that escape us. So what happens if the testis was down and now it is not? Well, secondary ascent, as I said, is real, and it can happen at any age, but it's very difficult to quantify because, of course, do we really know whether the testis was down and then it's up? Sometimes we even doubt ourselves in terms of the veracity of our findings, and so it has been very difficult to determine the real incidence of secondary ascent, but we do know that it happens. And in boys with retractile testes, there is a very broad range of incidence of ascent of these retractile testes, anywhere from as low as 2% to as high as 45%. Now, I frankly don't believe this 45% undescended testis number, and I think it's probably, as most of the data seem to sort of fall in between the 15 to 20% of retractile testes appear to secondarily ascend, and I would say that probably if you look at this number of being 6%, I think that what we're probably talking is the same phenomenon, that maybe 6% or so of kids with retractile of boys will have secondary ascent, and what's happening in this kid is that he has retractile testis and a risk of ascent because of a relatively short cord, as Suzanne, you and I discussed, this sort of taut cord that cannot be brought down. So it's probably not as high as 50%. So the biggest message that came out of the American Urological Association guidelines was do not perform ultrasounds or CT scans or MRIs or anything. There is absolutely no role for imaging in undescended testes. And parents will still, when we have diagnosed the undescended testis and we recommend surgery, will still ask, well, don't you want to get an ultrasound? And the answer is generally no. There is no role, and there's a very practical reason why. The goal is that the testis needs to be in the scrotum, period. If the testis is not in the scrotum, then you have to do something to get it there. So neither medication nor imaging will achieve descent of the testis. And so one could do all sorts of studies, but at the end of the day, we have, as pediatric urologists, we have a very well described algorithms, surgical algorithms for how we proceed to make the incisions to find out where the testes are and bring them down. Now, first, what we know is that 70 to 80% of the testes can be felt. Well, if you can feel the testis, then you know where the testis is. And if you know where the testis is, you don't need an ultrasound to tell you that the testis is there because you can feel that the testis is there. The second thing is that there's 30% of the kids who have non-palpable testes. Most of those testes are in the abdomen. Well, there again, you know that the testis is likely there, and you have to pursue that testis laparoscopically to bring it down. Now, some people would say, well, are you sure that it's in the abdomen? Well, I'm not sure that it's in the abdomen. It may be a dead testis, but I still have to confirm. I have to know whether it's a dead testis or an intra-abdominal testis, because an intra-abdominal testis would be at high risk for malignancy. And an ultrasound is only, as you can see, is only 50% sensitive and you know, only 80% specific for localizing a non-palpable testis. So, you know, since you're not 100% sure of what you're looking at, then you have to proceed with being sure. The one emergency that every pediatrician needs to be aware of is when you have bilateral non-palpable testes, even in what looks like a phenotypically normal male, because you always need to think of congenital adrenal hyperplasia. The underlying problem is a failure, a genetic mutation that produces failure of one of the steroid pathway enzymes. And as a result, and the commonest one is 21 beta hydroxylase deficiency. And the commonest problem that happens is then you end up not making enough mineralocorticoid steroids, and you have a backup of the precursors. And then the precursors get shunted down sex steroid pathways. And so as a result, there is this supercharged androgenic, you know, high testosterone state, which can result in almost complete virilization of a female infant to where they may look like they have a normal phallus, but of course females don't have testes. And so when one goes to feel, then no testes will be felt. So in anyone who does, you know, newborn nursery rounds, if you don't feel both testes in a baby, then you really have to be worried about this problem. And it is a critical situation because they can go into hypovolemic shock pretty quickly. And usually it happens between the second and fourth week of life. We do have a clinic downtown that focuses on counseling for patients with differences of sexual development. It's called the Proud Clinic. And I put the link there in case you need to make any referrals for children with DSD concerns. It is staffed It's a multidisciplinary clinic that is staffed not just with pediatric urology, but endocrine, genetics, and pediatric and adolescent gynecology and psychiatry as well.
Just so I'm sure you're aware of this, but all of the, at least in the state of Virginia, the newborn screen does check for congenital adrenal hyperplasia. I actually had in residency a 4-week-old boy who was ended up having was admitted for failure to thrive at 4 weeks of age, and he ended up having CAH, but he hadn't decompensated at the time. But he every time I took his, and I don't know if this was really honestly like, it should not necessarily be pathognomonic for it, but every time I took his diaper off, he would get an erection immediately. He was like, erection. And I had no idea if that was maybe the increased testosterone or not, but
yes, most likely.
Yeah. Now I always look for crazy erections and get worried about those babies.
Yep. There is an association between hypospadias and cryptorchidism. So there have been a number of studies that have looked at the incidence of karyotype abnormalities. And nowadays that we can do really fancy genetic testing, the number and type of karyotype abnormalities has increased. And so we always have to be wary about kids who have cryptorchidism and higher degrees of hypospadias for having a genetic abnormality. Now, while this may not necessarily impact the long-term psychosocial outcome of the child, but it may have an impact, of course, on fertility. And so it would be important for the families to know about these genetic issues. And this is part of the work that is done in the Proud Clinic. And now what about if you encounter the situation where you have bilateral non-palpable testes and you've evaluated them for CAH and they don't have CAH, their steroid hormone pathways are normal, it's possible they may have lost both testes. And so anorchia, while it is extremely rare, much rarer than having intra-abdominal testes, but it does happen. And again, ordering a sonogram is not helpful because the sonogram is not very sensitive. But hormone markers actually are. And so the testes will produce 2 hormones even before they have measurable testosterone production. And one is Müllerian inhibiting substance, which is the hormone that actually turns off formation of internal female genital structures, and inhibin B, which is a hormone that regulates FSH production. And so if the testis is not making inhibin B, then you would also have elevated FSH production. And the central axis would try to be driving formation of hormones by the testes, which of course are not there. And then of course the most direct way that you could do it is to measure testosterone, and the way that we would do that is to measure testosterone at baseline, do what's called an HCG stimulation assay, and then repeat the testosterone after administration of HCG, and then you see a commensurate increase in the testosterone in response to the HCG stimulation. And in terms of HCG, there have been actually 3 medications, I would say, or hormones, which have been tried as medical therapy for the undescended testis, and really overall the results of these is poor, and they probably really are only effective in resolving the retractile testis, which if you do nothing resolves itself.
Can I just ask you, which lab does where would you go to send a patient to get that testing done? Would that be down at Children's, or?
So the normal labs, it's basically just blood work for testosterone,
Right.
but it requires coordination by either pediatric urology
Right.
or endocrinology.
Got it. Okay.
Okay, because it would have the child would come into the office and get the HCG injections, and it
After
all
they
has
got
to be
the baseline testosterone.
Yeah, and it has to be
Yeah.
choreographed
Got it.
because
Okay.
a day or two matters in
Okay.
either direction.
So it's a referral. It's a referral to you or
It's a
endocrine.
referral, yeah.
Okay.
Yeah, it's a
Okay.
referral.
Perfect.
Yeah. And so the reason why, of course, we want to do this quickly is because we're trying to prevent loss of germ cells. This little cartoon basically describes how we do it. We make generally an inguinal incision for any testis that we feel. Increasingly, I'm doing what's called a Bianchi incision, which is a parascrotal incision, and you may see some of the kids come in with these incisions that almost completely disappear. And I'm able in a young patient to access the entire inguinal canal through basically a near scrotal incision. And what has to happen, I apologize, this is the best sort of little cartoon that I could get, but you have to essentially strip the tissues off the cord of the testis, which is being shown here. And these tissues essentially restrict the elasticity of the cord. What is included in this tissue kind of packet is that hernia sac, which has been pulled down into the groin as the testis migrates. And the hernia sac is supposed to close itself off after completion of descent. And because descent doesn't complete, then of course the whole process doesn't complete. And so now you've got a hernia sac present in the majority of kids who have undescended testes. That said, these hernias are often quite small and not clinically significant. And then you make a second scrotal incision, and you have to sort of do a thing where you pass the testis underneath the bridge of tissue, and then we sew the testis in place, and that basically secures the testis down. It's a very successful procedure, very low likelihood of secondary ascent. I've been doing this thing for about 20 years now, and in my hands, my average time now is 24 minutes for an orchidopexy. Kids stay in the recovery room for between 30 and 45 minutes. They go home. And as I tell most of the parents, the majority of these kids are running amok in the house the day after surgery, and you can hardly tell that they had surgery at all. For the higher testes, it becomes much more difficult to bring them down. And it's important to know that the intra-abdominal, these non-palpable intra-abdominal testes, they are complicated because of the fact that the blood supply to the testis is short. And so the higher the testis up, the shorter the blood supply. And sometimes what we need to do is what's called this Fowler-Stevens division of blood supply. And we divide the main arteries and veins and hope that the collateral vessels will grow up and provide the testis with blood supply. And you can see here that in terms of being able to bring the testis down successfully and have it survive, it's not as good as an inguinal orchidopexy, which is basically in the high 90%. So it's maybe 80 to 86% success. But then again, you're talking about bringing a testis that was intra-abdominal. So to begin with, we're going to skip because it's 8:50 and people probably need to get to clinic, particularly myself. I would recommend there is a very good diagram, a very simple diagram, which is, and then what I can do is I can make all of this available to you guys. I can send you my slide deck which comes from the guidelines, the AUA guidelines. And this diagram, if you can pin this up someplace, and it helps you really sort of figure out how to proceed. The other thing that I did for you all is that I provide I provide you with 4 slides on talking points, which you can use for the patients so that we are all speaking a common language, which I think is important. And so the talking points go from, what you would tell them about embryology and development. When they ask, the typical question is, how often do you see this? Next is, well, what are we going to do about it? And last, how is this going to affect my son's future? So you can sort of, also day-to-day practice. Lastly, we were supposed to talk about hydroceles, and hydroceles I'm only going to devote a couple of minutes to because they're pretty simple. Once you understand all of this issue of undus and testes, now you can really understand what the hydrocele is all about. And the normal situation, this little string here, this is the pathway of testicular descent. And this is that tongue of peritoneum that remains sitting as an island around the testis. And if there is a mismatch of fluid production and absorption, then you get a scrotal hydrocele. If the tunnel did not close, it failed to close, now you have a communication, and now you've got a hernia. And sometimes it will pinch off in the middle, and you'll have a hydrocele of the cord. And sometimes it will actually develop even larger. And so now you have a large hernia through which bowel can drop into the testis or into the scrotum. So scrotal swellings are a manifestation of what is happening basically within this peritoneal tongue of tissue that the testis followed in order to get into the scrotum. And your physical exam then can tell you what is going on here. And I rely heavily on physical exam. Again, sonography provides very little to me. And so if I squish on the scrotum and I don't feel the fluid disappear through my fingertips, so my fingertips are on the inguinal canal. So if I don't feel things disappear, then I know that this thing is closed. If I do feel things disappear, then I know that I've got some kind of a hernia, either a small or large hernia. And sometimes I will only feel something in the groin, and I don't really see anything happening in the scrotum. So the physical exam really can tell you a lot about what's going on in terms of the type of hydrocele. And I want to really plug this. The power of the pen light is mightier than the power of the ultrasound. So here's a perfect example of a scrotal hydrocele, which was transilluminated. And the transillumination shows you the testis. And I would really tell you that you're really getting not a lot of extra information from this $500 sonogram than you got from this probably, I don't know, $2 pen light right here. Now there are some, this is sort of your baseline. So what happens if you shine your light through here and you don't see this fluid-filled compartment and you don't see the testis? Well, so then certainly one is well within the right to obtain the ultrasound, because if there is no transillumination, now you're talking about a solid thing within the scrotum, and that has to be evaluated. And the best way then to evaluate that is with a sonogram. So with that, I thank you for your participation, and I can answer some questions in the couple of minutes that we have left.
Thank you so much, Dr. Pohl. This has been fantastic. Lots of great information. I just had a quick question. When I have some older adolescents and young men that I've noted have varicoceles, is that something I have to refer people for?
Absolutely.
Okay.
We rarely do surgery for varicoceles, but it is a complicated question that needs to be addressed. Okay. And the short answer is that the criteria for offering varicocele ligation has to do with growth arrest over time. Okay. So we track growth of the left, generally it's the left testis, right? So we track growth. Yeah, so we track growth of the left testis over time. And if they meet criteria, which is basically a 20% volume differential, then we recommend surgery, but surgery is not obligatory. And so there's a whole conversation that then goes on around that. So that's nothing that you need to worry about.
Perfect. Thank you.
Mm-hmm. Dr. Pohl, it's Michelle Sesko. How are you?
Great. How are you?
Good. Question on hydroceles. When are we supposed to refer those? Is it like 3 years of age still, or when If the run of
Yeah.
the seals, when do we refer?
Well, so it depends. If if it's a newborn with a hydrocele, then if it hasn't gone down by their first birthday, then I would consider referring that. But then it also depends on the size. So that fluid-filled scrotum, that fluid does nothing. It just sits there.
Mhm.
So the question is what hydrocele is problematic and what hydrocele is not problematic, right?
Okay.
So one of the benefits of having the testis in the scrotum is that it's an organ that you can feel, right? As opposed to most of the organs you cannot. So the reason why we perform regular exam is because we're looking for malignancies and the health of the organ. If a hydrocele becomes big enough and tense enough that you cannot perform the physical exam, then I would argue that that hydrocele now meets criteria for surgery. There are some hydroceles, as you all know now, that are relatively soft. You can feel the testis. You can move the fluid around in your fingertips and you can get a feel of the testis. And those hydroceles are asymptomatic. They're soft. They don't influence your exam, and they're not a problem. So it's part of it is of timing, and part of it is of the sort of the characteristics of the hydrocele. And then I would also say is, if it's a hydrocele that that reduces, which means that when you squish the fluid, the fluid goes into the belly, that's a hernia. And that's never going to go away. And so that you need to fix. So there's no, specific age cutoff for that. So that's, that's what it all depends on. And then there's some, let's say you have a 3-year-old and the mom says, hey, last week, all of a sudden his scrotum swelled up. So you don't want to send that right away because that's probably just a reactive hydrocele. And particularly if you can't reduce the fluid, if you know that the fluid remains in the scrotum, then that kid you should follow for at least 6 months, because there's a high chance, about a 30% chance that hydrocele will get better on its own. And then after the 6 months, if it doesn't get better, then you go through your whole algorithm. Okay, is it still big enough that I can't feel the testis? If it is still big enough that I can't feel the testis, now we've got a potential issue in terms of being able to monitor the health and well-being of this testis over time. I probably need to send this to the pediatric urologist.